conversation about where healthcare goes from here. I'm your host, Carlos Watson, the editor of Ozzy. I'm joined today by two terrific guests. Of course, Dr. Rod Hochman, the CEO of the Providence St. Joseph Health System, and Mark Cuban, whose Mavericks are about to make us smile again. Has been involved in business and healthcare for a long time, and we're going to have a good conversation with both of you. Rod, why don't I start with you? Clearly a crazy last couple of months, difficult for lots of people. What surprised you the most about what has happened to healthcare during this COVID-19 pandemic?
Well, I define the world as BC and AC, before COVID and after COVID. And, for everyone, we actually had the first case of COVID-19 at one of our hospitals. And that was back, believe it or not, in January 21st. So that really got us going early. And the rest of the country was still looking at, what are you guys worried about? And, then we had the nursing outbreak in Kirkland, Washington. So we really got on this pretty quickly, recognizing that it was going to be a problem. I think the thing that surprised us the extent to which this spread so quickly. And the fact was it didn't spread, it was actually here. And then just the response and, this interface between healthcare, politics, and all of that. For most of us as physicians and stuff, we're not used to a lot. We get some of that, but it's been pretty extensive, to say the least.
Mark, I was interested to see the moment this happened. A lot of people froze. Obviously, a lot of heartbreak. But I saw you right out there. You jumped right into the conversation right away. Why did you do it? What made you put yourself right in the middle of the conversation? Particularly as a non-medical guy, you weren't shy about engaging.
Well, first, it was just happenstance. The Mavs were playing the Nuggets, and we just happened to be playing on national television when the news hit that the NBA season was being suspended. And that kind of was the fulcrum for what was going to happen going forward. And I was just stunned. And, and obviously we were aware of what was going on. And literally coming out for that game, I didn't know if we would have 500 people in the stands or a full house. And it turns out we had a full house. So I thought, okay, maybe the wisdom of the crowds, maybe it's not as bad as I anticipated. But obviously, as we got into it and players tested positive, the season was suspended. And, I had given it a lot of thought of what would happen if we were suspended prior to that. And so when I got interviewed, I just told everybody what was on my mind, that we were going to take care of people, that this wasn't about the NBA, that this was bigger than basketball, and we had to worry about our health more than anything else.
Mark, that's interesting that you say that out loud, because in retrospect, I do think Rudy Gobert, the Utah Jazz player who ended up testing positive, that was one of the key turning points in terms of, I think, people taking it more seriously and different. And now, again, it feels like sports is playing a key role in maybe the opening up conversation. So I think it both played a role in people recognizing the seriousness and opening up. How do you think about that? I mean, I don't want to lob what feels like a softball, but I do as I sit here and think about it.
Well, yeah, obviously we need something. We're all going stir crazy, even with some of the states opening up, or all the states opening up to some point now. We need something to root for. We need something to get excited about. We need something communal, and sports can offer that. So if we can do it safely, then we'll come back, right? And the good news is, and I'll defer to Rod on this, there's improving news about vaccines, there's improving news about therapies, but on the flip side, there's always new uncertainties that are popping up every day as well. So we seem to be taking 2 steps forward and only 1 step back, but safety is always going to be first.
Rod, talk to me a little bit about the history of viruses and your experience as a practicing physician, as someone who's responsible for 13 million customers and patients. You got 100,000 caregivers who work for you. Have you seen something like this, if not exactly like this, whether it was HIV or whether it was the Hong Kong flu or other things? Have you been involved in these viruses or pandemics before?
Sure. So, I've been a physician for 42 years. So when I was an intern back in Boston, we were taking care of patients and we didn't know what was quite wrong with them. And that was living through the whole HIV thing. And we didn't even know how to protect ourselves. We didn't have any concept of that. So we really had a feel for that. I gave a talk about 5 years ago, and I said I was worried about 2 viruses. And everyone looked at me. I said, one are cyber viruses, and the second are RNA viruses. the crowd got the first one because everyone was looking at cyber community. They didn't quite understand the other. And I talked a little bit about SARS, about MERS, and about the nature of these types of viruses, their proclivity to spread, and all of those issues around that. So a lot of us in the medical community have been worrying about this for a long time, and it didn't really quite surprise us. It wasn't a question of whether, it was a question of when. I think the medical response has been good. I cringe when I watch the news, because what happens is they take everything like it's gospel. And those of us in healthcare know about half of what we say first is probably going to change, so we don't say it that loudly. The good news is I'm really, really optimistic about the vaccine research that's going on. We really have the most brilliant minds working on it. And there are a number of things that are happening scientifically that'll get us to a vaccine earlier than we ever have. So a lot of hope there. What I worry more about than whether we get the vaccine is that, are we getting ready to deliver it to over 300 million Americans? Do we have the syringes, the needles, and also just the logistics? You know, when we have an influenza, we probably vaccinate about 80 to 100 million Americans. Now we got to do everyone. If I was in government, I would be working on that now to understand who gets it first, where do they get it, how do they get it, because it's going to take us a while to do that. And that's our frustration, is that this response time and getting the logistics ready for what we know we're going to have to do isn't there. But you know, I'm optimistic on vaccines. I think the treatments are getting better. I think our testing is getting better, particularly understanding who has antibodies and who doesn't. Some of the antibody tests are better than others. And the other one for Mark is, you know, to get the players out there, I'd want to make sure before I got them on the court, that I've tested them. Yep. So that I know that I don't have any positives before the players go out on the field. So they're going to really need some really close follow-up and whatnot in order to make sure they feel safe, you know, playing out on the court.
Yeah, we'll take the Hotel California approach, where we'll quarantine everybody in one environment. You know, Hotel California, you check in, but you can never leave. And so, yeah, we're going to be very strict. This is not going to be traditional basketball. We'll play in one or two locations where people, you know, there'll be no fans. There'll be just essential personnel, and even limited at that. And players and everybody will be tested. And then once you're, you know, I think what ends up happening, we play X number of games before we go into the playoffs. Those teams that aren't in the playoffs end their season, and then each round of the playoffs reduces the number of participants. So it kind of, you know, self-protects itself once we quarantine them.
Mark, let me jump in here a little bit, because there are a couple of interesting pieces here. And Rod, you served up a bunch of them. But talk about the government response, Mark. And I'm not trying to set up an easy hit job or critique of the president. But I'm legitimately asking. It is a complex task to deal with the pandemic, to deal with kind of the economic tragedy that's accompanied it, to think about, you know, how do you deliver not just to 300 million Americans, but obviously you've got a global spread. So where do you think the president and the administration have gotten it right? Like, what gives you hope as someone who thinks and runs complex organizations? And then where do they go next to get better, to make sure that a year from now, whether or not they're in office, we all feel like, you know, we got better during this?
So there's a couple things there. And rather than trying to second guess, because look, when you have imperfect information, you make imperfect decisions. So no matter who was in the office, they were going to do things wrong. But as you look forward, and I'll parlay off of what Rod said in terms of logistics, right? On one hand, I think we will have a vaccine. I agree, you know, in reading some of the research and everything, and reading the documentation on biologic simulations using AI, and that's speeding up the process. You know, there's a lot of unique things going on. But I think where everybody's falling down right now, and Rod's going to have to face this more than anybody, we're going through this 180 turnover where we're going from most people having employer provided health care that at least gives them a shot at dealing with getting a vaccine or getting the support and dealing with the uncertainties of what comes next after we have a vaccine, to 150 million people are on employer-based health care prior. Now you take 39 million off of that as of now. Now all the numbers flip. And hospitals really are going to have a challenge, or going to have huge challenges, because those people that 39 million people who probably already had employer-based healthcare now are going to be on Medicaid, maybe Medicare, maybe the ACA, and the economics of hospitals aren't really being addressed, and the logistics of the expectations of hospitals aren't being addressed. The financial issues of dealing with all that above, because as much as we'd like to think that we can create logistics for testing and tracking and tracing and follow-up, unless we really have a plan for all the hospitals to address these issues financially and logistically, because the expectation from all of us is going to be to turn to our local hospitals, we're going to have a mess. And I don't want to put words into Rod's mouth, obviously, because he's got to deal with this more closely than anybody. But that's actually my greatest concern, because our healthcare system is not designed to address any of this yet. And I haven't heard anything from the administration or candidates, for that matter, on how we're going to reformulate the economics of hospital systems to deal with these things.
Rod, it's interesting. Mark, what Mark's raising, I had a conversation with Lloyd Minor, who's probably a friend of yours, the dean of Stanford, who runs obviously a big set of hospitals and programs there. And he was talking about this digital health revolution and how much this COVID thing is going to force that forward. Are we going to see more digital health, maybe less physical infrastructure, in order to try and efficiently deliver good health care to, as Mark is saying, many more people?
Sure. I think there are two parts of this. Mark is absolutely right on. We've looked at COVID in these different waves. The first thing was to take care of the COVID patients, figure out how to do that, take care of our caregivers, get through that first tranche that we're seeing some of that wind down a little bit now. The second is all those people that we put off all their health care. Half the number of strokes and heart attacks have our health facilities. Guess what? They didn't go away. They're out there. So we're seeing now, trying to catch up with taking care of people who have put off their health care. We've seen opioid usage going up through the roof because someone who had to have their hip done hasn't been able to get their hip replaced, all of that. So this next phase now is to try to catch up with all the health care that's been put off. Then the next wave that Mark alluded to is, guess what? Now everyone's lost their health care insurance. So what was there before? So we're going to have a lot of people looking for health care, but no funding for it. So that's the next part that we see. We're already modeling that out. So we see that as the third part of this thing that no one wants to deal with. No one's thought about how do we fill in all these gaps once people have lost their insurance, their COBRA is gone, everything else. So I think that's an important question that we need to start talking about with
that's the biggest question we have, in my opinion, Rod, because this is the future of healthcare. I mean, the way you look, according to all the numbers that you guys have published, you lose 9% on Medicare, right? Yep. And that's going to be your biggest provider. I'm one of these healthcare geeks. I read the MedPAC transcripts. I read medical loss. I read the Medicare healthcare reports and do little spreadsheets on it. So it's challenging, in how you do cost reporting and all this kind of stuff. So it's going to be really, really, really difficult to try to figure this out. And I mean, it's something that the candidates and the incumbents have got to focus on, and they're not even thinking about it. And I brought it up to the White House, as in my role with the Economic Council yesterday. And it was just like, we'll cross that bridge when we come to it. And that's going to be a disaster.
It will. I think you're right on target. We're trying to offer up some solutions to the feds. One of the ideas that we had was this concept: could we offer every American, regardless of whether they're insured or not, primary care coverage, so that the primary care doctors can know what they're being paid, but we assure that 330 million Americans get great primary care, regardless of their ability to pay. And it's not that expensive to do that, right? But it would really, as we've seen with COVID, if people had really good base care, we'd be in such a better position. So we're actually putting together white paper.
Yeah, you need a primary care, even if they're capitated, right? You need someone to act as a gatekeeper, so not everybody's coming to the emergency room and just overwhelming you. Yeah, and just getting primary care.
And this gets to Carlos's question. Carlos, we're doing 15,000 virtual visits a day now. 15,000. before this, we were doing, well, if you did 1,000, that was a big day. And it's going through the roof. So I think substantially this whole digitization of healthcare has finally, it's there, it's going to be with us. And I think a lot of people like the virtual. They like that ability to get care where they are, when they need it, how they need it, and have that kind of access. So I think we've crossed that river. That's one of the good things that's actually come out of this whole crisis.
Hey, Rod, Mark, keep going. I'm going to geek out with you for a minute on some of these policy ideas. If either of you were in office right now, in addition to the mandating or providing primary care for everyone, what are 2 or 3 other things that you think would systemically improve the healthcare situation, including not only better outcomes but addressing some of the cost issues? Give me a couple of other ideas.
Go ahead, Rod.
Oh, sure. What I've done, what we were hoping, we didn't think ACA was perfect by any means, and a lot of us in healthcare said, well, it's a start. Let's figure out how to do it. We're closing the gap at getting coverage for everyone, expanded Medicaid, and in those states that we expanded Medicaid, we actually saw healthcare improve. Outcomes were better, all of the things that we wanted. And then how do you fill the gaps for folks that aren't insured or kind of fall in the middle? So we had a whole bunch of ideas on how to do that, but then that got derailed. And what I look at is there are 2 extremes here. One was the repeal and replace, and then we went to Medicare for all. And either one of those 2 extremes wasn't where we thought we needed to go. So practically speaking, we need to fill some of those gaps and get coverage for people that's not employer-based, but isn't just, let's just throw them into the Medicare plan. So
Rod, I'm going to give you the answer there. And
Sure.
I had a study that was just finished with the RAND report before the pandemic hit. So the numbers aren't all 100% valid, but my company's self-insured. So I asked the question, what if the United States of America is self-insured? And effectively, under the ACA, in addition to the 1 or 2 options you had, there was a third option where the government basically offered a program. And here's effectively what it comes down to. It's called the 10 plan. And what it says is no matter how much money, no matter how little or how much you make, you never pay more than 10% of your income for all your healthcare, period. And it's on a means tested basis, so that if you're under 250% of the poverty level, you pay a $25 copay, nothing else. If you're above that, then it's graduated 3% if you make 40,000, 5% if you make 60,000, et cetera, up to 10%. But the key element here is you don't start paying premiums until you use the system. So you don't have to pay into the system, because what's insurance? Insurance is just effectively acting as a bank, and then you have to beg the insurance companies to get your money back. The government has the treasury, so they don't need that banking function. So shortcutting it, RAND came back and said you'd be able to cover the then population of 45 million people under the ACA for about break even what the costs are for the ACA for that population. Right. But for the users, you'd save $63 billion. And so I'll send you a copy of it. It works, and the RAND company, once we're able to publish it, when we're on the other side of this and update the numbers, it creates that alternative that you're talking about where people have a safety net. If you're below that 250%, it's effectively single payer. If you're above 250%, it's means tested, but you don't pay premiums until you use the system. And the numbers work according to RAND.
Well, there are 2 parts to it. I think the one part is to make sure that all Americans have some sort of coverage. But then the next issue is they got to make sure they have access.
Yes.
Because a lot of the problems with ACA and even with the Medicare program is I have Medicaid, but no one's going to see me.
Right.
And then we got to figure out on this whole we got to make healthcare more affordable. I mean, I'm going to be the chair of the American Hospital Association next year. And one of the things that we're on is that healthcare has to be more affordable. We recognize that on our side of it, that it's out of proportion. We're going to have to do something about that, because that's the other side. The other 2 elements are access and affordability. And we really have to work on that to figure out how. And that's somewhat what, Carlos, you were talking about. We think with virtual, there are other ways to kind of get at this affordability issue. As a clinician, what works, what doesn't work. We have so many therapies. This is we're the most over-medicated country in the world. It's insane. We see patients that come into our clinics that have 8 or 9 or 10 medicines, and half the time they don't need most of them. So there's a whole bunch of on the clinical side that we feel we could do to make medicine better and more affordable, which is what we really want to dig into. And I think, Mark, if we start where you're coming from, let's at least get everyone covered some way, shape, or form. Then we got to dig into the affordability issue and get real about what works, what doesn't work, how do we deliver care, what works, all of those.
Yeah, the clinical side obviously is critical, and doctors now, and better. But one of my best friends does a lot of doctor support on burnout and stuff like that, and it's very challenging. It's very difficult to practice medicine these days because the emphasis is all on financial. Particularly, you're seeing private equity buy practices and do roll-ups and make this about cash-on-cash returns, and that's the antithesis of healthcare. And then on the other side, when you start reading those Medicare cost reports and you realize that they throw in everything but the kitchen sink to try to influence what the rates they get are from CMS, that has its own set of challenges as well. And so I think we've got to deal with it on the delivery side and what we expect from our doctors, because we're putting them under too much pressure, making it difficult to practice medicine. And then on the flip side, how we cost things out, right? Because until you deal with the actual true costs, then it's very hard to really convert that into pricing.
Absolutely. Mark, I have to say, I am so impressed that you actually read the Medicare cost report.
Oh, yeah.
That's what we all do.
I'll tell you one of the things I did, and I'll tell you why. I'll tell you why I read them. I put out this hypothesis, and I sent this to a really far left think tank and economists. And I said, look at the city of Toronto and look at the city of New York. The city of Toronto has the same real estate costs. They pay the same amount for doctors. They pay the same amount for swabs and all their overhead and beds and everything. Yet what a hospital in Toronto charges the province of Ontario for healthcare is far less than what a hospital in New York charges. And I wanted to try to understand why, because they should be about the same, because all the overhead and associated costs are effectively exactly the same as it turns out. The difference is in how they cost report. We use a lot of activity cost reporting. They use actual cost reporting, and that gets to the heart of the difference in pricing. Because I wanted to try to have a better understanding, and that took us into looking at all the Medicare cost reports and all that kind of fun stuff. It's riveting.
So Mark, if you and I were designing the U.S. healthcare system, and you just look at the payment structure, you couldn't even conjure up how you could come up with this craziness.
Oh no, it's
we
ridiculous.
have these things called charge masters, and they're designed. We hate them, but they're designed around an insane system that you basically have to put all these costs here to get paid X and Y, and it's so confusing because there's no correlation between price and what people actually pay.
And except if you're just a retail customer walking in, you're the only one that gets stuck with the charge master problem.
Right. So it's kind of like if you walked into a restaurant, and depending on what your insurance is, you're going to pay about 10 different ways. Well, if you come into our place, you don't have insurance, we're going to take care of you. And we do $1.5 billion of free and unsubsidized care a year. If you have the Blue Cross Blue Shield, you're going to pay X dollars, right? And you're actually going to end up subsidizing. You and I, with our self-insured, all of that we subsidize the rest of the country, taking care of our people. And so it's this crazy cost-shifting system that we have that all of us believe is insane. It has to be changed. There's no question.
I agree. I asked a simple question of CMS. I said, okay, MedPAC, when they set the rates and the increases, go back and look at a benchmark. And some of those benchmarks were set in 1993 and 2003. And even in the MedPAC transcriptions, they say they don't know what the benchmarks are or how they're relevant, but they have to use them. I mean, so you have all these crazy pricing scenarios that they're using to set the price for everybody, and they don't know how or where they got to the price.
Yeah. The other thing, Mark, I don't know in all your readings whether you've ever looked at the Dartmouth Atlas. The Dartmouth Atlas takes all the Medicare data from every county in the United States and looks at usage. So it'll look at a county in Texas versus a county in Wisconsin or in Washington State. and say for the same population, age adjusted, everything else, why are there 5 times the number of cardiac caths in X county versus somewhere else?
It's crazy.
And this variability of care makes absolutely no sense. So just even on the clinical side, and just get online, you can kind of look county by county.
Yep.
And those are the kind of things that we have to kind of put a bright light on and say, wait a minute, this doesn't make sense.
Exactly.
So question to both of you guys. When I hear you describe this, doesn't feel like it's going to be easily solvable. It feels like a convoluted system.
No.
It sounds like there are going to be a lot of people who are beneficiaries. Mark, you're describing a new group of entrants and private equity guys who may also not have an incentive for it to get solved.
No, they shouldn't be there. They should not be allowed in the game at all. And I'm not saying this should be public. That's not what I'm saying at all. But look, to me, and Rod may disagree, this all comes down to cost, right? How we cost things out. Because CMS and others are focused on pricing and pricing transparency with the perspective that if everybody looks at the same price, looks at pricing and availability from different sources, then they'll pick the best price. But that's just not how people choose their healthcare, right? I mean, when your son or daughter breaks a leg, you're going to the closest, opportunity for care. And then on the flip side, though, I've done a lot of work on the actual costs, right? And the way hospitals, and I'm not saying this is Rod, but just across the board, generally, they throw in the kitchen sink, right? There's real estate, there's buildings, there's this, there's that, how they allocate overhead, even things that are forward thinking like social determinants. All those things, when you aggregate them together for cost, that same family trying to bring their child in for a broken leg, that goes into how they figure out their costs and then how they price. All these things have to be rethunk, as Rod said earlier, from the base up. But this is the best chance we're ever going to get to do it, because we need to rethink everything. And fortunately, Rod's at the forefront of doing a lot of these things.
So one of the things, Carlos, that makes a lot of sense. So we look at, we would love global payments in our health system, because we have doctors, we have long-term care, we have community care. So one of the things that we argue about with the insurers are, give us a percentage of premium, and then let us manage the health of the people we're taking care of. Because what we'd rather do is take care of folks at home, which we won't get paid for under the present system. We'd actually like to help them out with some of the social determinants, because actually that return on investment is incredibly good.
But Rod, let me ask you a question there. It can, not to interrupt, but should social determinants and some of the forward-thinking investments be separated into different companies? Because as you look to get that return, like any other business, you have to allocate some of that cost to some of the basics for your base consumers, right? The people you serve in the emergency room, the people that you want to offer primary care to. That kind of increases that cost, doesn't it? But, my orientation would be, if you separated social determinants and investments in new care and new therapies, then if there are different companies, you can go right to federal sources and go to other, charitable, whatever sources to fund those independently and get that great return, because it does provide a great return without impacting the costing or pricing of other more basic services.
So actually, Mark, I think some of that you can do. I think you can actually do both. But if you have a global payment, let's say if I had a global payment for you and your family, and it required that, we needed to do home care, we needed to do home monitoring, we needed to actually get Meals on Wheels for you, I want to pay for that out of the global payment. Because actually, from a health standpoint, you're going to do better. You'll come into the emergency room less. So this concept of global payment, particularly for large health systems, some of the ones you have in Texas and ours, it gives us a chance then to pay for some of those things out of the global payment that actually help the health of individuals.
Right. So you're saying you'd get a price per family, you'd get an amount per family, and you'd have the responsibility for all the families in your area or in your hospitals.
Right. And then all of those other things that we put under this rubric of social determinants actually have such a great return to do that, because then we're actually getting paid. Right now, the way we get paid, I got to drag you into my office. I got to drag you into the hospital or the emergency room. But if I got paid for taking care of your health.
It's proactive versus reactive.
Right.
Yeah. Now the question then becomes, and Carlos, I'm sorry, I'm taking your job here. The question then becomes, should that be run through an insurance company? right? Because look, there's no insurance company in the history of insurance companies, when given the choice between returning $1 to shareholders or reducing the price of care or a premium, is going to, put that last dollar to someone's healthcare, right? They're trying to optimize their returns.
Hey, Mark,
gone through insurance companies.
Mark, I want to put you on the spot here because you now have gone after them a couple of times, and you and I have talked before about whether you were going to run for office. And for 2 seconds, I thought you were running this year, but then you decided not to. Would you go after the insurance industry? I mean, the insurance industry ran over President Clinton in 93, 94. President Obama decided to do a little bit of détente with them in order to get Obamacare done. But if you did run, would you go right after the insurance industry?
No, I'm not against insurance at all. It serves a role, but you just have to understand insurance is just that. It's a financial instrument. It's not a healthcare instrument. And once you understand it's just a financial conduit, then it just competes with other financial opportunities, including competing where the government needs to play its role. So I'm not against healthcare companies at all, but when they pretend to be, insurance companies at all, but when they pretend to be healthcare organizations, which they're not, that's what creates the disconnect for me.
But you and I know that the impact of what you're saying, if you applied it, would be to dramatically shrink that sector, right? I mean, you're saying that there is
actually, if you go back to what Rod said, and Rod, correct me if I'm wrong, they should be more profitable because Rod's taking a lot of the risk off of them and a lot of the reaction and a lot of, what everybody talks about is the associated overhead of dealing with transactions, right? The coding and then dealing with each contract and renegotiating each contract each and every year, which just adds to the administration costs. By doing the per caps and capitation and dealing with the approach that Rod had, all that gets just crushed and reduced significantly, right? Which is bad for the insurance companies because they take their top line and then try to get a percentage of that. And so there's this misguided incentives where, hospitals, I'm not saying Rod, in a non-capitated environment, try to increase their revenues because they work on a percentage net, and insurance companies, that's all they deal with. When they look at their medical loss ratios, 15% of a bigger number is always a bigger number, and so I think there's just misaligned incentives, and that's what I'd address with insurance companies.
Guys, I'm going to move the conversation just a little bit, but I love that, and that's interesting to hear that piece of it, Mark. Rod, talk to me a little bit about mental health care. I know it's something that you've thought a lot about, and I know you're thinking about it even as we're talking here, but a lot of people hearing us talk here would assume you're talking about diabetes, you're talking about stroke, you're talking about a lot of the physical kind of healthcare, but I assume you also are factoring in medical care here. And in fact, that might even be more important given what we've just gone through.
Oh, absolutely. So I said two things. When we did a merger with St. Joseph Health about 5 years ago, we started the Wellbeing Trust. And we said, we're going to put a stake in the ground about mental health. We put $100 million to get it kicked off, to really bring this issue to the forefront. And what we're seeing, what we're worrying about a lot with COVID is we're worrying about obviously the deaths and disability coming out of COVID itself. We're worrying about all the concomitant medical diseases that have been put off. But what we're also is the next wave is what we call the deaths of despair. And those deaths of despair come from suicide, alcoholism, and drug addiction. And we're going to see that wave. What we're worried about with all that's going on, there's going to be a big wave of that. Mental health was a big problem that we were digging into before COVID. We think it's even going to be a bigger issue later. About 30% of the people that we're seeing in our clinics and hospitals have some sort of concomitant behavioral or mental problem that goes along with it, whether it's depression or others that are with it. And we think this has been a travesty in the United States that we really haven't dealt with mental health effectively. So we think that's an important part of anything we do to fix healthcare in the United States has to be the identification and working at mental health problems. So it's a big deal for us.
Mark, how do you think about this? Because you probably see it as someone who runs a complex organization. You know that your employees' mental health has a ton to do with their physical health, has a ton to do with their happiness, their productivity. How do you think about this mental health care question broadly and as it relates to healthcare and insurance and all the things we were just talking about?
Riley, how you feel above the neck is just as important as how you feel anywhere else. Because if there's something wrong, emotionally or any perspective, you're not going to be effective. And, put aside the business side of it, I just try to be concerned for their well-being as a person. And it's really hard to because it's so qualitative as opposed to quantitative, it's really hard to discern the best way to approach these things. And so, when I see Rod get into a lot of these things with Providence, that's a good thing, right? But it's still challenging because, you want to give your employees or your stakeholders, whoever, the best care, but it's hard to know what the best care is. And that's the biggest challenge from a business perspective.
So we've been digging into this, Carlos. I think one of the important things is our caregivers, particularly with COVID going on, the stress they're under. We actually put an online program in place for every one of our caregivers, where they, depending on where they are on the spectrum of need, we can get them the appropriate care in place. And I would say we're doing a better job, Mark, about quantifying mental health issues. So if I look at your company or my people, the number 1, 2, and 3 medications that they're using are anti-anxiety medications and antidepressants. So we're getting better at quantifying the degree, what are the interventions that can be used, and a lot of things. We talked about telehealth before. One of the areas where telehealth's been really effective has been mental health, particularly in young people. Young people would actually talk to a therapist or a nurse or a doctor on a screen than have to walk into an office, say, oh, here I am, So actually we're finding, like with telepsychiatry and telepsychology, there's a lot of folks that are using that to good benefit. But we're starting to really dig into how we quantify mental health. What are the issues that are out there? How do we find the early warning signs, particularly in children?
Yep.
And young adults? Suicide's a leading cause of death in some of our young adolescents that are out there. So that's something we're really kind of think we can dig in on, and we have to put it out in the open. And I think mental health, before, if you had cancer, you never talked about it. If you had HIV, you never talked about it. I think mental health is that next frontier where people have to open up about, hey, it's something we need to talk about.
Yeah, I agree. And keep on going, Rod. I mean, the challenge again from our side is how do I choose Rod? How do I compare Rod's programs to X company, Y company, and Z company? Because everybody's coming in saying they have the best solutions and they have the best insights into providing that care. So the more tools you give me to make a decision, Rod, the better decision I can make.
Right.
Hey, Mark and Rod, I want to get personal for a little bit. I'm curious about how both of you came to be interested in these healthcare questions. And I could make assumptions, given that we all have our own health to think about and family members. But Mark, clearly you've got a level of passion that goes beyond just the casual.
I got my modern healthcare subscription right here.
Hey, Rod, if you haven't spent time with Mark before, he seems to be a geek about just about everything. He seems
absolutely.
Readers about.
I'm amazed at how you can get up to speed on all this, Mark. It's amazing how you could do it because these are great issues, and it's so exciting to have you interested in healthcare. We're going to latch on to you. And as I'm
I don't know. I regret
that. I'm going to be on the phone with you.
Anytime. Well, I'll answer your question, Carlos. About 3 years ago, when the whole repeal and replace thing was coming down, and I started realizing that if there was a repeal and replace of ACA, they didn't have a solution. There was no response. So, I mean, just one of those days, it's like, okay, I'm an entrepreneur. How would I do it differently? And so the first question I asked was, what do I do for my companies and how's it working? As I mentioned earlier, we self-insure. And then I just started digging in more and more and more. Now it's been, 3.5 years of just geeking out on healthcare every chance I get, and battling it out with Zeke Emanuel about the positives and negatives of the ACA, going to these conferences and going back and forth, digging in with the Rand Corporation, and everybody, when I come in, everybody takes my call, right? But nobody really thinks I'm serious. And so I have to be that person that really gets down into the weeds of all this stuff and truly understands the numbers and the impacts and the results in order for people to take me seriously. And so that kind of propelled me.
And Rod, what about you? I mean, I know you're a physician, and obviously I know long before you were an executive, you were actually delivering healthcare. But how did you get into it? Was your mom a doctor? Your dad a medical professional? How did you?
I'm the son of two immigrants. They came to this country after World War II in 1950, and both kind of said. And for my dad, I had two choices: it was lawyer or doctor, and I went with doctor. And that was it. So whatever. And when I was 16 years old, we had a program. I grew up on Long Island. I was born in New York, and it was called the Doctors of Tomorrow, where physicians were mentors to high school students. And I spent a summer with an orthopedic surgeon when I was 16 years old, and that was it. And I said, okay, this is what I'm going to do for the rest of my life. And I think it's really helped me as a CEO to have talked to families. I still have patients that write me notes that I took care of 15 years ago, 20 years ago. And so that, I think in healthcare that, we have some clinicians that have come into this because they've actually been with families, they know what's there. But at the same token, what I love about folks like Mark is that a lot of folks that are new to healthcare, so I've been hiring people like crazy from Microsoft, from Amazon, from T-Mobile up here, because I know what I know about healthcare. I want them to challenge me about what we're doing. So it's been a great mix of tech people and healthcare people. When you put those two together, magic happens, because we both kind of teach each other about what's going on. And I think that's, some of the breakthroughs that I see as we need to really reform and change healthcare. We got to get the technology people, we got to get people like Mark together with the folks that have been at it for 40 years like me. When we get together, it's kind of exciting.
Wait till I tell you, Rod, wait till I tell you about the API we're building in Dallas for hard to get drugs.
Right.
And the drugs we're going to give away. Yeah. So we're going to do a whole cost plus drug company. We've already started building it out in Dallas. And then on top of that, we have some E. coli specimens that for insulin that if we can get to work, hopefully will be some game-changing things there as well.
It's fantastic. And what I found with COVID is the collaboration that's going on now.
Crazy.
People are actually each other in the scientific community. We got all of our clinicians and scientists from 7 states all working together on projects. The minute COVID hit, what the first thing we did was we called all the scientists in Italy and China and the clinicians and said, okay, you guys have been at this for a while. Tell us what we need to know. We think some of our results were better because we actually talked to the folks that were doing this stuff. So it's really the good thing coming out of this is this collaboration about how to figure out how do we get drug costs down. We started a company called Civica RX.
Yep, I know Civica really well. Yeah.
Right. So we said, hey, we can't put up with generic drugs. The folks at Intermountain said, are you guys in? I said, I'm in.
Yep.
And it's been a great example of how we collaborate. We think this around healthcare data that we got to get the big health systems together to figure out how to use this information in a way, what I would say for good, not evil, to really figure out how to accelerate change in healthcare. So those are the things that, for me, are exciting out of all the things that are happening.
Hey, Rod, Mark, I know we are coming close to conclusion here. I want to hit you guys with a couple of rat-a-tat-tat questions, if you don't mind. And so, Mark, I'm going to start with you. I'm going to give you my hot 6, and I'd love your immediate quick take. So, sure. 1 sentence or less. Has Texas managed its COVID response well or not?
Medium.
What happens to hospitals over the next decade? Are there more of them, less of them, about the same in terms of the physical structures?
Fewer hospitals, more remote facilities.
What country in the world do you think has impressed you in the midst of this COVID response? Are you paying attention to?
I don't know enough. I haven't been paying close enough attention to that side.
How bad is this recession going to be?
Worse. How
long do you think until we see a recovery, if you had to guess today?
Depends what the federal government does. If we have a transitional federal jobs program, 3 years. If we don't, and we just leave it to entrepreneurs and guys like me, pure laissez-faire, 5 or 6.
Last of your hot take questions. What are the chances that you leave basketball behind now that you put in Luka's hands and you focus all your time on on healthcare going forward?
Zero. Negative. Zero. If I didn't have an outlet, I'd go nuts.
I love
that. You got a game, right? You see me scream at the referees the whole game?
I do.
That's how I de-stress.
I do. All right, we're going to come back to the basketball in a minute, and I'm going to put you on the spot on your TikTok dancing. I caught you dancing on TikTok with your daughter. You did all right, though. She did better, but you did all right. Rod, let me come to you.
Sure.
Same sort of thing. A couple of hot takes here. Rod, homelessness, will it get better? Will it get worse over the next year, given all the various factors that are at play?
It's going to get worse before it gets better.
Talk to me about funding. Do you expect to see a surge of healthcare funding from the Trump administration to help deal with all that's happening in and around COVID?
I think it's going to be an ongoing struggle, and we've got to keep educating as to what we have. But I think it's going to be a struggle.
I know you and every other healthcare professional is worried about a reoccurrence in the fall. On a scale of 1 to 10, 10 being the worst, how worried are you about a very damaging reoccurrence?
I'm a 5. We got to get on influenza vaccines now so that we take some of that out of the equation. I think we're smarter than we were 3 or 4 months ago, so I put it at a 5.
You talked about the fact that there are a lot of things that haven't gone away, but we just may not be seeing. You talked about strokes and other things. Give me 2 or 3 other things that are unfortunately not being focused on now, and that this summer we're going to have to address maybe differently than we have over the last 3 or 4 months.
So mental health, big, is going to be a crisis there. And the other one I worry about are cancer patients. They've been putting off treatments. A lot of biopsies haven't been getting done. And that's one of those things, Carlos, we won't see maybe this year, but it's one of those things we're going to see a year or 2 from now. All of a sudden, some of the good results that we've been having, we're not, we're going to see some disturbing trends.
Mark, help me wrap up here. We talked about a lot. You guys have made me think about the level of collaboration that's happened here. You've made me think about some of the policy choices that maybe we have going forward, which is kind of interesting. I love just hearing about the API that you're building in Dallas.
I lost you, Carlos.
Lost him. I think we're going to have to wrap it up here. I don't know.
Hey, Rod, let me ask you
today. Kind of help me wrap up.
Okay, well, Carlos, we lost you. Rod, masks, right? Here's the question I have on masks. On one hand, I get why everybody wants to use them, right? You protect everybody else. Yep. You're sick. But on the other hand, I'm reading more and more about viral load, right? Yep. That the level of sickness or impact is dependent on viral load. But the question I don't know is if you are sick and you're asymptomatic and you don't really know it, and you put on a mask, which means in essence you're confining your own personal viral load, can you make your own sickness worse?
No.
Look for data, and I haven't seen that.
No, it's so variable. When we think about this viral load issue, I think what we're going to find, and we're actually doing some studies here in Seattle. It's a difference in your own immune system to the way you react to. I think that's going to be a bigger factor than viral load. So yeah, viral load will play a role, but we've seen folks that have had relatively little exposure that have a really incredible response to this virus and end up being really sick. So we're going to understand more about the differences in our immunity amongst individuals, and we're actually doing work in the lab to look at that, to see what are the genetic factors that make my immune system different than yours. Right. We get the same exposure, yet we get a different reaction. So not a factor. If we can get the masks on, it really does help in terms of transmission rates, particularly in inside environments where we have a harder time controlling the density of people.
Okay, one more. See, Carlos, I'm throwing out all my conspiracy theories, right?
I love it. I
don't get access to the expert.
Go get them.
Meatpacking plants, right? And so we've seen meatpacking plants, not just in the United States, but around the world, right? And as a business guy, just looking at their economic drive, it would seem to me that those packing plants would do everything possible from keeping those line workers get sick, right? Yet you're seeing a recurrence of it in meatpacking plants over and over again. Is it conceivable that it's jumping from, just like it went from a bat to a human, is it conceivable it's jumping from cattle to human?
No, no. I think that the real problem there that we face is there's so many asymptomatic carriers, so that we think we've got everyone, and all of a sudden there's another outbreak because there's someone who's asymptomatic. So what I would be doing if I had a meatpacking plant, I'd really be testing, and we've done this in nursing homes. When we test everyone, or able to do that, we get a handle around who's asymptomatic, who's not. And then in the workplace itself, separation helps, mask helps. In a place like a meatpacking plant, shields, you got to have shields. Those are the places where I would suit my folks up a little bit the way we suit up some of our folks in the hospital to be able to do that.
This is the one I'm going to disagree with you on. Just looking at the numbers, and look, I'm just guessing more than anything else, right? Just hypotheses. I'm going to guess that this was around longer, and that there's a transmission there that is happening, because it's just happening to you. It's just happening in too many places that are taking those precautions.
How long?
So the other one that I'll tell you is then there's different populations that unfortunately are more subject to COVID than others. So it's a lot of our service workers, and particularly disproportionately African Americans and Hispanic Americans are in those jobs in those meatpacking plants. They also live in homes where there's multi-generational. That was some of the
more susceptible to get transmitted.
So I think there's other factors, but it's always important to kind of look at all the variables that are there. But we're seeing some of the same things in assembly plants, like we saw the Ford plant have to close down again. So it's a balance. So more than likely, it has more to do with proximity, the population of folks that have to work there, all of those things.
You're saying there's a chance. So there's,
like I would say, as scientists and clinicians, what we try to do is weigh the probabilities. That's what we're trying to tell the public. We can never make it completely safe, but we know we can do a lot of things to keep it relatively safe. So you're absolutely right.
Well, thanks for hearing me out on my little conspiracy theories. I appreciate it. I had to be able to dispel those or have a smart opinion on in response to them.
Right.
Hey, Rod, I know we're wrapping up, but I want to go back to what you talked about in terms of racial disparities. And you talked about the number of African Americans and Latinos who often are on the front lines, who've been disproportionately, in many cases, impacted, including death. Do you think this leads to any fundamental change in terms of racial equity in our healthcare system going forward? And then, Mark, I want to hear you on the same question. Is there an opportunity, in the same way that there may be changes in digital health, there may be changes in financing in our healthcare system coming out of this COVID, there may be changes in collaboration, even in testing, any changes in racial disparities going forward, Rod, do you think? And, I mean, real change, not just talk, but any real change you think that will happen as a result of this?
Yeah, I do. I do. When I think about all our, what are some of the benefits that can come out of this? We've been talking a lot about racial inequities in terms of treatment before this. What COVID's done is really highlighted it. So we think it's like with mental health, it's a now issue that's not going to go away. So we're really going to continue to push on that. Going to look at all the issues around how our care really needs to be democratized amongst folks, and we've got to own up to those facts that there are inequities in the type of care that's being given, and it's been highlighted what we've seen in COVID. Because when I look around the country, if you look at New York, you look at Detroit, you look at which hospitals in New York that disproportionately had most of the COVID patients. I grew up in the city. It was Elmhurst. It was Jamaica. It was those hospitals that were serving disproportionately the poor and vulnerable population. So we're going to keep on this topic, and we're not going to let it go.
Mark, how do you think about that? Because I know you and I have talked about that before in the entrepreneurial world. What are the possibilities for kind of bridging that gap? How do you think about that in healthcare?
I mean, I'll look at it from the corporate perspective, because companies are going to have to be a lot smarter, because if you're not more compassionate about your lowest paid employees, they're the ones that are most at risk, as everybody knows, as Rod is confirmed. They're taking public transportation. They're in multifamily households or larger family households. They have lower income, and so they're able to take fewer precautions. They have to go to work. They have to take more risks in order to feed their families and pay their bills. And when you add all that up, that introduces more risks in the corporate environment. So if companies aren't more compassionate and don't take better care of their workers, don't pay them more so they don't have these same obstacles, then they're putting their entire corporation and business at risk. And so smart companies are going to do that. Companies who haven't figured it out are going to find themselves in facing a lot of problems financially, because as we've seen with the aforementioned meatpacking plants and nursing homes, those businesses are getting decimated because they weren't smart enough to address these issues from the bottom up.
Hey, Rod, I know that we are at the end of the hour here, but bring us to conclusion. What did we not talk about today that you wish we had raised as we finish up? And then Mark, I'm going to come to you with the same question. I know we got to a lot of good things today, but what did we not get to, Rod, that we should have touched on?
What I think collectively as a nation, we need to really rethink things about our supply chain, particularly in healthcare, that we have got to. It is to me unconscionable that the United States was brought to its knees on $2 masks and $5 gowns. And I just shake my head. And that one isn't on one person or another. It's on all of us, that we should never allow ourselves to be that dependent on things that are going to happen somewhere else. So whether it's on pharmacy, drug supply, medical supply, and then listen, I want to pay extra if something's made within the United States. I think we're going to see a lot more of that. And then I think a little bit of a movement from, necessarily everything being more shareholder value to a little bit of more what's the common good. And the common good, has a real return on investment in the long term for the country.
Mm-hmm.
Mark, when I heard him say that, I heard Oak Cliff. I married Robert, what you were saying was, should we set up a factory in Oak Cliff? Should Mark and you and I, should three of us set something up there where we're actually producing, Mark, this PPE that we need? Is there that kind of opportunity when you talk about creating new healthcare companies? Should we go exactly into the communities that are most at risk and create some interesting economic opportunity there to actually address the larger need?
Well, of course, to Rod's point, right? When you're smart about things and you look at the greater good, you do get a return on investment. And we're only good as a community, as a country, as our weakest links, because all of our costs, all of our productivity challenges come from having to readdress people who fall through the cracks. That holds us back, and that's unfortunate. Hopefully, we'll take this kind of reset we're going through economically and use that as a means of becoming a more compassionate capitalist society, because I truly think that this is going to create unique opportunities that when we look back in 20 years, there'll be 10, 20, 30, 50, who knows how many companies that are world-changing, world-class companies, because the one thing this country does better than every other country in the world is start businesses. We are entrepreneurs at our core. And so those folks out there, and then the next question becomes, where do those great ideas come from? They're going to come from some 16 or even a 61-year-old kid or person who's broke, stuck, and everybody thinks they're crazy and is going to have that world-changing idea and makes it happen. So as horrific as it is, as difficult as this is, I agree with Rod. There's so many opportunities that we can fix ourselves, but there's so many opportunities that we can create to make it even better. And hopefully, we'll see them and we'll enable them, and that'll take us to a better place.
Guys, thank you both. And I'm going to have to end on a little basketball here because, Mark, I'm a junkie too.
I know you are.
I know Rod enjoys it too. All right, Mark, you saw during this close down here, everybody was talking about the all-time greats. Where are you putting LBJ on your list of all-time greats? Let's get to that.
So I'm going to hedge. I said if I start a team from scratch, I start with Michael Jordan. If I have a team that is already good and I need a finished piece to win a lot of championships, I go with LeBron, because LeBron has a better basketball IQ. Michael has. Yeah.
going with LeBron over MJ
No, as a finishing piece, right? So if I had the Celtics from the 80s and I needed one more piece, and I would take LeBron because he knows he's more of a distributor. He makes everybody on the court better. If I needed one guy to start a team around or to carry a team, I'm going with Michael Jordan because Michael Jordan can carry a team better than LeBron can.
All right, Rod. Rod, you finish us off. Give us your all-time five. Rod, who's your starting five?
Well, all I can say, I'm gonna be a grandfather for the first time in October.
Okay.
My daughter lives in Chicago, and it's gonna be a boy. She already let us know, and she's already got the first name, and it's Jordan. So
really?
I'll leave it at that. So.
I love that. I love that. Guys, hey, thank you so much for such a thoughtful conversation. Rod, I've always loved what Providence St. Joseph stands for. I love how you guys started off with, as I call it, a bunch of renegade nuns 60 years ago. And Mark, as you said, sometimes it's the people on the outside who create the biggest, longest lasting change. And PSJH obviously represents that in the best way. So thanks to both of you, and thanks to all the good folks who made this happen today.
Thanks, Rod. Thanks, Carlos.
Thanks, Mark.
Okay, be safe, guys.
You guys too.
Take care.